Okay, good afternoon or good morning, wherever you are today. This is, of course, Friday, noon Eastern Time for another one of our fabulous episodes of COPD Navigator Live, our weekly look into the world of COPD and related information. My name is Mike Hess, and I am a respiratory therapist. This week's episode is going to be a special tribute to many of my coworkers. We are just at the tail end of Respiratory Care Week, an annual event that kind of celebrates our profession and tries to bring some new light to the things that we do for a lot of people in healthcare. I do like to call us the best kept secret in healthcare, because while we are in a variety of settings and cover patients from the smallest little premature neonate, preemie baby, all the way up to great-great-great-grandparents, a lot of people don't really know what we do, and we tend to be mistaken for other professions. So I'm going to be talking about that a little bit today, and of course getting to your questions as we go through the program today. I am going to start, as I always like to do, with some news updates from the world of COPD. We've got a couple of interesting studies to talk about this week. First off, a study coming out of China recategorized a lot of COPD patients in one of their national health studies. Many of you may know that just about a year ago, the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, issued the latest revision of their international practice guidelines for the management of COPD, called the GOLD strategy. And one of the key features of this has been a new way of looking at how severe a person's COPD is. It used to be based strictly on limitations in their ability to exhale air, particularly in the first second of a forceful exhalation. But now the GOLD strategy is taking a much closer look at symptom burden and exercise tolerance and how much COPD actually affects someone's life in order to determine how severe their case was. They found over time that looking just at airflow obstruction wasn't really comparable to looking at things like, it didn't really correlate well with how well they could get about their daily life. It didn't really correlate well to mortality predictions, all that kind of stuff. So GOLD decided to take a new look at how they're categorizing stuff, and then now a year on, this study from China has used the new guidelines and compared them with some of their older patients, older guidelines, to see how things matched up. And what they found was actually about almost half of the people, about 46.7% of the people who originally were found to be in a high risk for future exacerbations kind of severity group, actually needed to be recategorized into the lower risk groups. They found they were able to kind of lock down a little bit more what led to high risk, or what gave a person a high risk for future exacerbations, and they recategorized these groups and looked to see a little bit about what kind of treatment we should be doing for this variety of patient. Now, it's not entirely clear what that means, even from a clinical standpoint. You could make the argument that this is an indication that because we're a little bit more accurate in categorizing how some of these people are, their severity, we can make better clinical decisions when it comes to disease management and medication management, and trying to make better, maybe step down some of the therapy that they're on. Maybe some of these people are being over-medicated. You can also make the point that there's some question about whether these new GOLD strategy, these new GOLD classification guidelines are realistic. It's possible that people who we have considered to be low risk are not actually low risk, and we should be doing a better job at determining that. So the question is still going to remain for a while. Again, these are very new guidelines. This is only a year old, which in terms of medicine is almost a blink of an eye. It was a couple of years until the previous iteration of the GOLD recommendations were actually tested, and then that's when they found that those needed to be refined even more, and that's what gave us these new called the 2017 guidelines, recommendations. So it's going to be a few years yet, but this is a first step in looking at some of that data. Another study we have today, a lot of studies coming out of Asia right now. We've got another study from Taiwan that has linked occupational exposures like dust, fumes, and even secondhand smoke to increased risk for the development of COPD. Of course, for a very long time, COPD has been regarded as strictly a smoker's disease and has been treated pretty much accordingly. A lot of times people have a little bit more of a dim view about COPD. We've all heard stories about clinicians telling people, well, you should have known better, you shouldn't have smoked, so on and so forth. But now, as research has gone on, we've seen that there are more and more non-smoking related types of COPD out there, and a good 20 to 25% of people with the diagnosis have never actually smoked anything in their lives. And now we're starting to see why with studies like this new one that have come out that are linking what we call environmental exposures, like if you're at work and you're not using proper respiratory protection and you're exposed to fumes and dusts and again even secondhand smoke, you are at increased risk for COPD. It's been a known thing that you're at risk for things like pulmonary fibrosis and that sort of lung disease, but this is more evidence that people who have exposures to pollution are at higher risk for COPD. And that's important for a lot of people, not just at an occupational level, but we have to look at people who live in areas with very high lung or air pollution who would also be at similar risks. We see that people who live next to highways or near factories in areas all around the world that have maybe heavy air pollution, maybe not quite the limitations that we would like to see. We do see that those people are likely also to be at higher risk for developing the chronic lung disease known as COPD. And finally, this is very applicable considering the time of year we're in and the time of year we're approaching, at least here in the northern hemisphere. I know every now and then a friend of Navigator from Australia likes to check in. A certain friend of ours from Australia, Russell, likes to check in from time to time. And I just saw he posted that he's getting ready for his first swim of the year. But up here in the northern hemisphere, we are looking at well into fall. Actually, I had to scrape some frost off my windows this week, and we're looking at snowfall for the first time in our local forecast here in Michigan. And of course, this is flu season. We're coming into some of the meat of flu season here, especially as we get into December, January, upcoming months here. So I wanted to mention that there was a poster that was recently presented earlier this month, I believe it was, at ID Week 2017 out in California, Infectious Disease Week out in California. And this poster studied, it was a small group, it was about 130 patients who had COPD, but they did find that taking the flu and pneumonia vaccines were associated with fewer exacerbations, fewer hospitalizations, fewer intensive care admissions, less time on ventilators for those who are really severe and have to be have the breathing tube and go on a ventilator, and arguably most important, a lower number of deaths. So this was kind of a big deal. It maybe goes somewhat without saying, but it's always nice to have extra evidence to support our clinical practice guidelines and to make the recommendations that pretty much everybody who is in an at-risk population, certainly those people with chronic lung disease like COPD, emphysema, chronic bronchitis, that whole umbrella, and as also the healthcare workers like myself, the respiratory therapists, nurses, everybody else who deals with that high-risk population should be vaccinating themselves as appropriate. And that means every year a flu shot, and at appropriate times a pneumonia shot too for particular populations. So that is kind of our news summary for the week. That's something we like to do all the time. For those of you who may be new, a couple of notes today. What the genesis of these respiratory or the COPD Navigator live talks came out of the Facebook group that I operate or administrate on Facebook, facebook.com/groups/COPD Navigator. We've been doing that for a few years now and doing these live talks every week for not quite a year, but they've been a great method of getting some information out there and trying to give people an opportunity to ask some questions from a healthcare professional. Again, I am a respiratory therapist. I've been focusing on COPD for a few years now. And I mentioned that again because today is kind of a trial run. As we come up on November here, I was asked by the COPD Foundation to do these a little bit more widely. These have been available through the COPD Navigator group and on my personal page for a little while now, but I'm partnering with them to cover some topics for COPD Awareness Month coming up starting next week. Today is kind of a technological test to make sure we've got all of our bites in a row, so to speak, and to see what kind of information we can get out there to make sure that these videos for COPD Awareness Month go off with as few hitches as possible. Of course, when we're doing something live, there's always the chance for that sort of thing to happen, but we'll just have to see what happens. So at this point, I will take a moment to say hello to the variety of people who have already popped in and said hello today, from longtime members like Jim and Mary and Linda McMahon, Kathy, to some newer friends out there who I hope you're going to get some good information today, and hope you'll join us again next week as we start getting into some of the real meat and potatoes talks. So what I would like to talk about today, as I mentioned at the very beginning here, this is Respiratory Care Week throughout the United States. This is an official week that we celebrate every year, and try to bring attention to, again, as I said, what I like to call the best kept secret in healthcare. A lot of people with chronic lung disease do have some experience, for better or for worse, with respiratory therapists, as we are commonly one of the first people you may encounter in the ER, or if you get admitted to the hospital, we're the people who come around and do the breathing treatments, and we listen to your lung sounds, and we sometimes pound on your chest if you have a lot of mucus in there. We are kind of the frontline clinicians when it comes to pulmonary disease. But a lot of people don't really realize who we are, what we do. And so I wanted to take a few minutes today and kind of delve into that a little bit, because we actually have a very rich and interesting history that goes all the way back to the early 1940s, as a matter of fact. The roots of our profession are generally agreed upon to go back to a hospital in 1943, where a doctor named Edwin Levine established what was then called an inhalation therapy program. Dr. Levine was trying to improve outcomes for his patients who had operations, post-surgical patients, and were trying to come up with better ways to improve their lung capacity after surgery, and after they had been on, again, this is going on 70 years ago. This was a whole different ballgame when it came to trying to keep people alive during surgery. We didn't have the ventilators we do now. We didn't have a lot of the post-operative care that we have now, we kind of take for granted. Anesthesiology was entirely different back then, and so this whole concept of inhalation therapy was meant to try to improve those outcomes. So a few years went by, and by 1946 they had actually demonstrated a lot of improvement, and so a lot of other places were trying to jump on this bandwagon of inhalation therapy, which created this need for what was then known as the Inhalation Therapy Association, which was the very beginnings of our Respiratory Care Professional Society, which is now known as the American Association for Respiratory Care. And the Inhalation Society, again, tried to create a scientific basis for a lot of the therapies and a lot of the treatments that people were trying to do to improve these outcomes, and trying to boost quality of life for people who came out of surgery and needed some help with their breathing. Of course, once we get past the 40s and into the 50s, we had a major health crisis in the United States that many of you may recall, or at least be passingly familiar with, which was the polio epidemic. Obviously, that started maybe late 40s, but really into the 50s is when we often consider the polio epidemic times, and we had a huge need for respiratory support. Back then, the standard of care was to put people inside the iron lung, which is considered what we'll call a negative pressure ventilator. Basically, the way that works, for people who may not be as familiar with polio, It's a progressively debilitating disease that takes away your muscle strength, essentially. And a lot of times that will, of course, impact your ability to breathe. And so what would happen is we would put these people in these giant tubes where their entire body was covered up to about here. And we would reduce the pressure inside the tube, which if we go back to physics class, I'm not going to get into too much detail with that, but we go back to physics class, and when there's less pressure out here, that's going to make your chest expand, and that's going to suck air basically into your lungs. And then, of course, we put pressure back in, compress everything back down, push the air out. And so that's a negative pressure ventilator, and that's how these iron lungs worked, and that's what was keeping people alive throughout this polio epidemic. And actually, up until the last couple of years or so, we actually have had people still living on iron lungs for this many years. I want to say the last person in an iron lung passed away about last year. But every now and then I still see a news article pop up that says the last known surviving person on an iron lung is in such and such a place, at such and such an age, et cetera, et cetera. But it worked well for the technology we had at the time and kept people alive when they otherwise would not be. And so in the middle of that, in 1955, we actually had the first national public meeting, the annual meeting of the what was then called the American Association for Inhalation Therapy. And you can kind of see the evolution from the inhalation therapist to the AARC. And a year after that, we had our first publication of our professional journal, which was then called Inhalation Therapy, is now called Respiratory Care. And if I may take a moment to promote myself, I had my first publication in that particular journal actually announced yesterday. We actually went to press on it yesterday. Came out in our current edition of Respiratory Care, and is specifically about those new gold strategy recommendations that I mentioned a little bit earlier, and how they're going to impact respiratory care practice in the coming years. So that was exciting. That was a good celebration for Respiratory Care Week and getting us ready for COPD Awareness Month at the same time. As now, we've gone into about 15 years now. Our profession is starting to mature a little bit. We're starting to get a little bit more scientific basis for what we wanted to do, for what we did and what we were doing to people. We, of course, didn't want to just be random people off the street coming in and doing these breathing treatments and doing these pressure therapies and all that sort of thing. We realized that we had to have a very foundation of education and foundation of clinical excellence in order to support what we were doing. And so in 1960, we put forth an effort to create a national credentialing exam, and actually toward the end of that year had our first national credentialing exams where we had what we were registered inhalation therapists, or what we now call registered respiratory therapists. That was where we actually first had our first evidence of professional competency, where we had started having these credentialing exams. And so, of course, the next few decades saw a lot of growth, and then in the 1980s, and when we started getting into the post-polio epidemic, or the post-polio syndrome care and all that sort of thing, we saw kind of another sort of explosion in respiratory therapy. In the 1980s was when the personal computer era started, and our ventilators started seeing that same kind of growth up until, of course, in the 50s, as we mentioned, we had these iron lungs, we had these negative pressure ventilators, and then as we got into the 60s and 70s, we started discussing this concept of positive pressure ventilation, where we actually put in a breathing tube, an endotracheal tube, and we connected a person to a machine that would basically pump the air in and then suck it back out. Instead of doing that work from the outside with negative pressure, we actually use this machine to apply positive pressure to blow things into the lungs and make the good air in and take the good air or the bad air out. And so this was the era of positive pressure ventilation. And by the time the 80s rolled around, we started seeing these ventilators being controlled less by pneumatic valves and more by microprocessors. We started seeing the computer age really blossom into the medical field. And in 1982, I believe it was, President Reagan, after after that assassination attempt, spent a lot of time in the hospital, spent a lot of time after surgery, spent a lot of time with respiratory therapists. And he was actually the first president to issue the first national proclamation of Respiratory Care Week in recognition of the work that his RTs did in helping him recover from that assassination attempt and do much better. Obviously, he survived for many years after that, so the RTs down there did a fantastic job getting him back to health. And so the combination of that and the combination of the dawn of the microprocessor age really enhanced the need for respiratory therapists throughout the hospital system. And of course, we also saw a big growth in the field of what we can now call non-invasive ventilation. We saw that we could apply positive pressure through those breathing tubes to keep people alive and keep them breathing, but we also discovered at the same time that we could use a very similar concept with just a mask. Now, of course, we use that. That's basically our frontline therapy for things like obstructive sleep apnea, and even when we're trying to keep people from going onto the ventilator, because we see with certain lung conditions, including COPD, when you go onto the ventilator, when you go onto the breathing machine, you have an increased risk of complications, and sometimes it's difficult to get you to come off that breathing machine. And so we're trying a lot harder now to use these things like non-invasive positive pressure ventilation. A lot of times you'll hear that described as BiPAP. I try to shy away from that because technically BiPAP is a registered trademark like Kleenex and Band-Aids, and we don't want to get too far into using that in a generic sense, but we use this positive pressure ventilation to try to keep people off the ventilator. We're also seeing a growth in the amount of declarations of Respiratory Care Week. I was very proud. This week here in Michigan, here in Kalamazoo, Michigan, we're able to get for the first time that I know of an official city proclamation recognizing Respiratory Care Week from our city commission. Earlier this week, I had the pleasure of visiting one of our very local respiratory care education program here in Kalamazoo Valley Community College. Got to share the proclamation with the next generation of respiratory therapists, and I was very excited to spend some time with them and one of my former instructors. I'm a proud KVCC graduate myself, and also excited to say one of my classmates is following in the footsteps of our instructors, and she's now the clinical educator over there at KVCC. So it's an exciting time for our field. And so where we are at a modern time is our biggest, in my opinion, most recent accomplishment was we had a dozen or so respiratory therapists who participated in the formation or the initial writing of the COPD National Action Plan, a document that came out earlier this year that was pushed for by the National Institutes of Health, was very much advocated for by the COPD Foundation and the American Association for Respiratory Care, and respiratory therapists had a major impact in having that written. I myself was one of the goal team leaders, which was very exciting, a tremendous honor, of course, and we were very gratified to see a lot of the work that we put into that has started coming into fruition. Where we are as a profession these days, according to the Bureau of Labor Statistics, looked up as of this morning, we have roughly 130,000 respiratory therapists in practice throughout the country right now. We are in a variety of fields. The vast majority of respiratory therapists you will find in the hospital, whether it's in the intensive care unit or in the ER or the pediatrics unit, where we usually serve in the acute care setting where we're trying to get people over their immediate illness and get them back into fighting shape, so to speak. But you do see a great many respiratory therapists out in pulmonary function testing, in sleep laboratories where we're trying to screen and test and diagnose for things like obstructive sleep apnea. And we have some oddballs like myself who work in regular physicians' offices. We work in case management. I work in a primary care office. And we're trying to, right now is a field of tremendous growth and excitement, right now is a time for tremendous growth in our field. And we're really excited about a lot of the different avenues that we're getting ready to pursue. So how do you become a respiratory therapist? Right now, the basic standard is getting an associate's degree. There are programs throughout every state in the union right now that offer the associate's degree in respiratory care, and that is the foundation of our, much like nursing, that is the foundation of our credentialing exams. We have a couple different exams that we take to become first a certified and then a registered respiratory therapist. And in order to be eligible for those, you have to have an associate's degree. Again, much like our partners over in the nursing field, we are working diligently to increase our minimum standard up to a bachelor's degree, as this will give us a little bit more flexibility with some government regulations and things like that. And in my personal opinion, more education is virtually always a good thing. We also have a few programs out there at the master's, and I believe we do have one at the doctorate level. But once you get past that bachelor's degree level, a lot of times we're starting to see some diversification. Personally, I'm working on my master's in public health right now because I have seen the issues that I have struck the COPD community, and I want to be able to do a better job, frankly, with managing that. Our profession is very scientific. We have a lot of equipment that we like to play with, so to speak. We have everything from mechanical ventilators, which are probably the pinnacle of the technology we use right now, all the way down to airway clearance devices like our friends the Acapella and the Aerobica, very simple mechanical devices that you blow through to help knock out some of those respiratory secretions and a lot of other junk that fills up your chest from time to time. The key to our profession is not necessarily technology. In my personal opinion, a lot of times the oldest ways still work the best. We want to make sure that we get everybody as educated as possible on how to effectively manage their disease themselves, whether it's COPD, whether it's asthma, whether it's cystic fibrosis, whatever it is. Self-advocacy is one of the keys, and that's where that's why we're pushing for an expansion of respiratory care services into a variety of settings so that people can benefit from what we bring to the table, and we can do a lot of teaching. So, as kind of a summary on the initial the first half of our program here, respiratory therapists are a valuable part of the healthcare team. Of course, I'm a little bit biased about that. But we have a lot to offer in terms of clinical experience, and we have a lot to offer as far as disease management education. And so I'd like to just take this last moment here for this first part of our program and say a very happy Respiratory Care Week to my fellow professionals out there. And if you see a respiratory therapist, thank them for helping everybody breathe a little bit easier. So. And for those of you who may be new to the program, what I like to do is the first half we have a topic of the week, which of course this week was respiratory therapy and respiratory care week, and the second half of the program is kind of an open forum. I like to open up the floor to a lot of general questions out there. Generally speaking, we focus on the COPD world. These questions don't have to be necessarily 100% dedicated to the topic of the week, but they can be whatever happens to be on your mind. I did see one person who Margaret asks, I would like more information on COPD because she has COPD. And that's very much what these topics are, and very much going to be the first bit of talking in COPD Awareness Month. Coming up next month, we're going to be doing 4 weeks of COPD topics. We're going to be covering everything from medications to disease management, to pulmonary rehab, to exercises you can do, to diagnostics. We're going to be covering a lot of that topic every Friday in November at 1 p.m. Eastern Time. And then we're also going to be working on getting these as Facebook Live events. They are available on Facebook. And then as we I'm working on getting them uploaded to YouTube too as well for an archive. So hopefully, if you have a more specific question about COPD, please feel free to fire it off here in the comments section. Otherwise, hopefully we'll get to your questions or what the things that you're interested in over the course of COPD Awareness Month. So Lucy asks, what are the best things to use? My doctor has me on Thera-WHAT, theophylline, Spiriva, Symbicort, ProAir, and Brovana. Are these the best, or are these better things out there? Well, that is quite a pharmacopoeia right there. Spiriva, and this is where I will also disclose that I am not employed by or paid by any pharmaceutical company, manufacturing company, or anything like that. I have no industry connections. I'm not even on any speaker panels or anything like that. So any opinions rendered are of my own, hopefully as unbiased as possible, or biased at least only by experience. These are, for the most part, those are fairly common. We don't see a lot of theophylline use in the U.S. anymore. It does pop up from time to time, but we do have three main types of medications that we use. Beta agonist type medications, which are bronchodilators, antimuscarinic bronchodilators, and steroids. Those three things are covered in a control sense by Spiriva, Symbicort, Spiriva and Symbicort. Symbicort is a combination med that has that long-acting beta agonist and a corticosteroid, and Spiriva is the third leg of the chair, so to speak, the third leg of the stool, the antimuscarinic. Brovana, which I believe is arformoterol, is kind of duplicating what you're getting from Symbicort, so that might be a little bit of a redundant drug if you're taking that every day. You're probably doubling up on that. You might be able to cut back on that one, just depending on what the rationale is for your physician ordering that one. ProAir is perhaps better known as albuterol, and is an excellent rescue medication. It just doesn't last very long, which is why we use that for symptom flares and that sort of thing. So that is definitely part of the standard of care. And our last medication there, Thera-WHAT, generic name roflumilast, is a fairly new medication called a phosphodiesterase 4 inhibitor, or PDE4 inhibitor. And what that does is that works to bring down some of the inflammation inside of the lungs without being a steroid. We've seen a lot of side effects, especially with chronic steroid use, and even though inhaled steroids do tend to stay in the lungs for the most part, there is a certain bit that, especially over time, kind of leaches out into the general body system at large. And so we're trying to experiment with that a little bit more. Oh, I shouldn't say experiment with it. It's been approved for a few years now. So we're trying to lock down with a little bit more detail exactly who the best person to use that is. Because we also see a fair bit of side effects in certain populations. A lot of gastrointestinal kind of side effects, diarrhea, nausea, that sort of thing. But it can work very well, especially for people who have frequent exacerbations. And trying to keep you out of the hospital a little bit more, trying to keep those flares down a bit, and see how all that stuff goes. So it's definitely a very broad spectrum array of medications. As far as which one is best, it really depends on your individual biochemistry. Everybody's system is a little bit different, and so we see certain medications work better for certain people and others work better for others. The keys to that are technique, making sure that you're able to use your inhaler properly and that you know how to use your inhalers properly. And some people have difficulty using things like, for example, Spiriva comes in two different formats: a dry powder inhaler, which can be a little bit difficult to use, and a soft mist inhaler, which can be easier to inhale but sometimes is a little bit harder to get ready. So it really depends on what the best medication is. Really depends on your individual circumstances, your individual capabilities, and your individual treatment goals. I can tell you that you're covering all the bases, and if those things are working for you, then you're in good shape. So hopefully that answers that for you in as complicated a way as possible. Pam asks, can the Trilogy and the Astral 150 take the place of mechanical ventilation, or are there still other reasons to use mechanical ventilation besides during surgery? And to recap a little bit here, the Trilogy and the Astral, those are two different, those are what would fall under kind of the non-invasive ventilators for the most part. They deliver that positive pressure often through a mask and try to avoid having that breathing tube drop down in there. As far as whether they can 100% replace mechanical ventilation, the answer would be no. What we're trying, mechanical ventilation is a pretty invasive, intense kind of deal. That's why, I mean, invasive is built into the name there. We do that in the world of COPD. We often do that particular when somebody has a particularly bad exacerbation of symptoms, a flare-up of their symptoms, and they're not able to breathe sufficiently on their own. They go into first what we call respiratory insufficiency, and then later on into respiratory failure. And that can happen for a variety of reasons. It can happen to just not being able to clear out the mucus. It can happen because of fatigue. It can happen because your airways are so inflamed and swollen up that you can't move the air. There are a variety of reasons that cause it, and so what we do is we put the person on a ventilator to kind of take care of some of that work of breathing and to make sure that they're not actually actively suffocating, while we treat the underlying condition. We can treat the inflammation, we can treat the fatigue, whatever it is. We try to get rid of that underlying condition so that the person can then breathe on their own again. As I said, we see a lot of complications from that. It can be difficult to liberate somebody from the ventilator, especially when their lungs are a little bit weak to begin with. So we're trying to do a better job at avoiding putting people on there unless we absolutely have to. And that's where those non-invasive ventilators come into play. To a certain degree, that's going to be your Astrals and your Trilogies. More likely, it's going to be a device like what's called the V60, which is something you do have in the hospital, and you're on that, and you're getting a lot of those benefits of getting that. You're able to rest a little bit more, take some of that load off, that work of breathing off. But you don't have the complications that are involved with having that tube down your throat. You don't have quite as much of the sedation or things like that. Where the Trilogy and the Astral really come into play is before the hospital. We're trying to do a better job at keeping people out of the hospital to begin with, because nobody goes to the hospital unless they really, really have to, and so that's kind of this place where bad things tend to happen. So what we're trying to do is do a better job at managing everybody's symptoms before you get there, so that we can avoid these discussions about whether to put somebody on a ventilator or the non-invasive to begin with. And so what these devices do is these help take the load off on a daily basis. A lot of times you kind of have the concept of an exacerbation isn't necessarily 1 minute you're fine and the next minute you're in the symptom flare. Oftentimes you kind of trend down a little bit, and a lot of that is you have a bad breathing day because of the weather or because you had a respiratory trigger, and so you get a little bit weaker and you get a little bit more tired, and then as you get more tired you're less effective to take a breath, and so then you get more tired, and then your secretions start building up, your mucus and your phlegm starts building up even more, and then you get even more tired, and you start huffing and puffing, and your carbon dioxide level starts rising and rising, and then you start getting a little bit goofy, because that's what happens when your carbon dioxide gets too high or too fast. And so when we start using a device like the Trilogy or something like that, we can help take some of that load off, especially at night or while you're at rest, and we can start building up your reserve a little bit more. You get a little bit of a chance to rest. You get a little bit of a chance to redevelop your muscle strength. You take a little time off while not having the risk of passing out and going farther down the exacerbation slide. And so they don't really replace mechanical ventilation, but they can certainly work to avoid it toward the beginning of things, and to help keep you on the straight and narrow path rather than, like I said, going down that exacerbation curve. So that's where those things stand. We've got a little bit of time left here if we've got some other questions out there. As I said, we've got a nice array of topics lined up for COPD Awareness Month. If I can just pull up the list here real quick. I just need to do a little bit of tapping here, so bear with me for one moment. Our topic next week is going to be a fairly general talk. COPD basics, or COPD 101, so to speak, if we've got any college kids out there right now. We're just going to be covering some of the basics about what is COPD, how you get COPD, what are some of the main symptoms, how to recognize symptom flares, and some just kind of a very broad overview. And then, of course, we'll go into a little bit more detail with the question and answer period. And then the week after that, we've got a talk called The Medicine Cabinet, where we're going to go into much more detail about some of the medications that we talked about today, the different kinds of the different types of medications, the different types of delivery systems, what's the difference between a nebulizer and an inhaler, why would I choose a dry powder inhaler over a meter dose inhaler, all that sort of thing, and of course questions. Friday the 17th, we are going to be talking about breathing techniques, where a lot of breathing techniques and coughing techniques and even some tools that you can use to clear out some of these secretions and to help you breathe a little bit better even without the use of medications. To wrap up the month, we're going to be giving thanks for Thanksgiving, and we're going to be talking about oxygen, which is always a hot button topic, especially in the more severe phases of COPD. People start to use supplemental oxygen, so we'll talk about how to recognize when you might need oxygen, how you get tested for that, and some issues around its use and getting it paid for through Medicare. Or through other insurance companies, which is often an issue. And I would like to thank the COPD Foundation for their support in getting these topics together. I will be mentioning a lot of their services as we go on through here. They have some fantastic programs available through their sponsorship, including, as I mentioned, if you are having trouble with getting your oxygen reimbursed, or if you are having issues with a supplier, they have an excellent advocacy program. They have a program called the State Captains Program, which we'll talk about a little bit more next week. I myself am a state advocacy captain for Michigan to try to get some of these things a little bit broader view. Actually, I'm very excited. I have a meeting with one of my state senators coming up in a couple of weeks, just after COPD Awareness Month starts, and I'm going to be able to bend her ear a little bit and talk about how we can raise the profile of COPD, specifically in Michigan. But I would like to get a higher profile throughout the whole country, and of course, that's where the National Action Plan comes in. So that's going to be an exciting time. Karen mentions making sure that you take all maintenance medications as directed every day. That is absolutely true. And I see I missed a couple of things here. We're going to scroll back up a moment, but I do want to cover that real quick. We do have two main types of medications in COPD. We've got your controller medications that you should take every day as directed. Some of them are once a day, some of them are twice a day. But those are the things that improve your, what we call the baseline symptoms for COPD. And then no matter how well you're controlled, there are going to be days and times where you have those breakthrough symptoms. And that's where the rescue medications come in, like albuterol. So we've got those two different types, and it is very important to get your optimum treatment. You're going to take those controller medications or those management medications every day according to how they're prescribed for you. So let's see, I'm scrolling back up a little bit here. I'd like to say hi to Diane, one of my fellow RTs, a co-worker I used to work with at my previous job, and I learned a lot from her, and she has a great deal of experience in home care. So she's going to be a fantastic resource for anybody out there, of course. Pam, love my RTs. Thank you very much. Put them right up there with a pulmonary doctor in regards to great information from both. Well, we certainly try. I will tell you that much. I by no means am a pulmonologist or anything like that. I certainly don't have the depth of education that they have, and I have a great respect for all of my physician colleagues. But we do offer a lot. We do bring a lot to the table in our specialty. So. Margaret asks, what would be good to keep flare-ups away? Well, that's going to depend this may sound like a little bit of a cop-out, but that does highly depend on your individual triggers. Some people, if you walk around a public gathering, like if you're going to church or even in a store, grocery store, something like that, a lot of people get triggered by certain fragrances, cleaning chemicals, that sort of thing. So of course, identifying triggers is probably the best. Making sure that you're getting into as optimum shape at baseline as you can, making sure you're taking those controller medications, making sure you're talking to your providers about pulmonary rehab, making sure you're taking advantage of breathing techniques or programs like that. Pursed lip breathing is a big one. We'll get into that in a couple weeks, but for a very broad view, basically taking a breath in and blowing it out through some pursed lips. Not quite a whistle, but more like trying to cool off a spoonful of soup. That can help keep some of those symptom flares away. Making sure you're right on top of any kind of bad breathing day or anything like that. A lot of places out there now, a lot of practices are starting to have kind of a rapid response pack where you might have an antibiotic and a steroid, a dose of antibiotic and a dose of steroid and things like that. You call into your provider and say, hey, I think I'm starting to get a flare. Well, should I get my pack? And they'll say, yeah, we'll call that into the pharmacy, and you go get your stuff and you get right on top of that. Dr. Brian Type, who is one of our leading COPD experts, likes to analogize these COPD flares to forest fires. If you can get on them early, you can put them out right away and go back to business. But if you let it wait, then they just grow and grow and grow, and then it's a lot harder to take care of them. So managing your symptoms every day and then staying right on top of things. If you start seeing changes, especially those that may last longer than 24 hours, get on that right away. And of course, identifying your triggers. And I would probably be remiss in saying perhaps the most important thing you can do if you do happen to still be smoking is to quit right away. That's going to be an ongoing thread as we go through a lot of these COPD Awareness Month talks. Quitting smoking and exercise are probably the two biggest things you can do to optimize your management, your disease management, and keep yourself as healthy as possible. So. Karen fires that up. Also, avoiding things that trigger flares is important for minimizing exacerbations. Absolutely. I mean, 100%. You got to stay right on top of these things and know what sets you off. And it can be tough. It can be tough to learn that stuff, especially toward the beginning, because everybody is triggered by different stuff. This isn't necessarily something that, if you have a bad knee, you run. Everybody knows if you have a bad knee and you run on it, or if you abuse it, it's probably going to hurt. COPD isn't quite like that. We did a talk last week about trying to recognize what normal is, and unfortunately there isn't necessarily one normal in COPD. Everybody has their own different normal, and everybody has different triggers and different symptoms, so it can be difficult. Sometimes people do forget to breathe. That sounds sort of like an apnea kind of talk, where you do have, sometimes people do struggle, especially at night, where the brain kind of shuts down and forgets to tell the rest of the body to breathe. And that's where some of these overnight sleep studies and things like that come into play, and we can start doing some diagnosis on that sort of thing. So. Kathy mentions only about 20% of smokers develop COPD, and I don't have the stat. That's one of those stats that I don't have off the top of my head. I would suspect it's a little bit higher than that. Unfortunately, we have not done a great job with screening and diagnostics over the past few decades. We are starting to do a better job. We have tools like one that's called the Capture tool. That's basically a 5-question screener that looks at some smoking history and some symptoms. A lot of times we'll look at a peak flow measurement where we'll find out exactly how much air you can blow out, as far as how fast you can blow it out. We have seen that a lot of people tend to dismiss symptoms, especially early symptoms of COPD, as getting older or just being out of shape or things like that. And certainly that can be the case. But we also see that we're missing a lot of those early stage or early phase COPD patients, and we can slow down their disease progression if we do a better job of screening and diagnostics. So 20% may be a number that's out there, but I suspect the true number is higher because we already know we're only capturing about half of the people with symptoms with the right diagnosis. So I suspect it's going to be higher. It is true that not everybody who smokes comes down with COPD, just like not everybody who smokes gets lung cancer. Not everybody who overeats gets obese or anything like that. And we don't know why. We're doing ongoing studies into some of the genetics behind COPD and how that stuff works, but we are lagging behind other diseases in our knowledge. And hopefully things like the National Action Plan are starting to change that, but we do still have a long way to go. So let's see how to help patients afford medications. Many older patients hit the donut hole and come into the hospital in the fall. That is absolutely true, and that's something we struggle with here, even in primary care outside of the hospital. And that will probably be something I go into a little bit more detail as we go into some of the strictly medication talks. It is difficult. There are certain assistance programs out there. Each of the drug manufacturers usually has an assistance program, but they can be difficult in terms of a lot of paperwork. And certainly it's difficult to qualify financially sometimes. They have different cutoffs. There's not a lot of consistency. There are some local programs that can help with pharmaceutical costs and things like that. But that is a major issue in COPD management right now. And that's one of those things that I hope to address in my conversation with my state senator coming up and other legislators as we build on this. It's tough. There's not an easy solution because you've got a lot of competing interests. You've got the companies, you've got the government who oftentimes is paying for these medications, you've got individuals who are trying to afford them, a lot of stakeholders involved with a lot of conflicting interests. So hopefully we can make some progress on that before too long, and hopefully we get that donut hole closed before too long. But some of these things again just unfortunately take a lot of time. Oxygen concentrators are great for in the home, and even portable ones are improving in their technology all the time. It's just again a matter of getting some of this stuff paid for. Why is it when you go to the hospital they just arrest you like you're a mother number for cops instead of treating the underlying problem? Different places, different clinicians and different facilities have different practice standards. Unfortunately, there has been a reluctance to push people, and certainly we do have to be careful when somebody is in the middle of an exacerbation. They are going to be somewhat limited on their activity. We don't want to make we don't want to make issues worse. That's kind of the first rule of medicine, is to do no harm. But it can be tough because we have to strike the balance between pushing somebody and between letting them lay there and decompensate even further. It can be hard to strike that balance, but we do need to make sure that we're pushing people to their ability. So I don't have a very clear answer as to why you go there or why that's the case. You should get some rest, but you don't necessarily just want to rest. And so I agree that that's something we need to work on. But as part of the National Action Plan, we are trying to develop a little bit more standardized system of care, a little bit more standardized education to improve our care standards and our best practices. So that's perhaps a question that is more directed at your individual provider. Hopefully you don't go back into the hospital, but if you do, might be a good question to ask your hospitalist or whoever's managing your care, why aren't I getting up and around when that's the best practice? So we do like to advocate for that and encourage that as much as possible. Jim and Mary mentioned the Lung Institute, and I will mention them briefly this time around. We'll talk a little bit about more of that as we start getting into some of the other therapies out there. For those who don't know, I haven't heard of the Lung Institute, I would say count your lucky blessings there. The Lung Institute is a program that claims to be able to cure COPD through the use of stem cell therapy, usually by sucking out fat cells from your body and doing some kind of special wash or voodoo magic or whatever, and injecting them back into your lungs. Unfortunately, while that sounds great and while stem cells do offer a lot of promise for the future 20, 30 years from now, we are not there, and they have no evidence to support their claims. They're claiming a miracle, and they're charging you about $5,000 to get this done without any kind of evidence that what they're doing is better than a solid management plan with good exercise and nutrition and proper med management. So they are getting kind of aggressive in a lot of their things because they definitely want a lot of money. But if you, my 10-second advice on them is anything that says Lung Institute, avoid it like the plague. We're getting close to the end here. We are talking about changes in season. How long can you live with COPD? I'm 46. That is an excellent question. That's an excellent. That's something that many people ask, and the answer is that again, there's not really a good answer for that. There are people who are diagnosed in their 40s that we're able to get them onto a good management plan, and they're able to live well into their 70s. There is a specific type of COPD where you do tend to lose lung function very fast, and so it's a little bit faster. It's difficult to make these kind of predictions, and that's why, especially as we start looking at symptom-based care and symptom-based severity, that's one of those things where we looked at that what we call the FEV1, that airflow obstruction, that first second of blowing out very fast. And that's where our traditional staging was, because we kind of looked at big populations of people and we saw that we could kind of, based on how that compared to their predicted value, we could kind of make some assumptions about how severe they were and maybe make some very general assumptions about how long they had to live. But unfortunately, we see that is not a very good predictor at the individual level. We can still make some very broad predictions at the population level, but as we drill down to the individual, we can't really make those calls anymore. And so it's very difficult. It is very possible to live for decades with COPD if you can keep it well managed and you can keep your exacerbations relatively low and keep on all of your medications and all that sort of thing, and new technologies that are coming out all the time. But I also, at the same time, don't ever want to make anybody any false promises. And also the most honest answer is that we don't know. It is possible to live a very long, full, productive, fulfilling life. But some people do get sick very fast, and the optimum thing is to add as much life to your years as possible, and that's where people like me come in, and we try to optimize your plan, and we try to get you tuned back up with pulmonary rehab and that sort of thing, good exercise, good nutrition, a lot of those aspects, and we try to get everything, we try to give you your best possible life. We've got a couple more questions, and we're going to wrap things up. I want to hit, because it's in honor of Respiratory Care Week, one of my fellow RTs, Christy, asks, do you feel they screen for depression appropriately? I think depression is a big reason for non-compliance and non-adherence around her facility. And I will say unequivocally, 100%, that is correct. We often do not look at some of the mental issues that surround chronic disease in general, but specifically a chronic disease that impacts virtually every moment of every activity that you do in your waking life, and even sometimes in your sleeping life. We do not often look at depression, anxiety, and a lot of that stuff. And even up until the last few years in particular, we haven't really looked at that at a clinician aspect either. There was a huge study that came out about a year, maybe 2 years ago now, by Dr. Barbara Yawn and her associates that looked at this concept of treatment nihilism, which is a fancy way of saying there's nothing we can do. And as recently as 2007, a huge percentage of clinicians, generally speaking, providers like nurse practitioners, primary care doctors, physician assistants, that cohort, felt that there really weren't any effective management strategies or therapies for COPD. And so it was kind of well, you've got it, there's nothing we can do, have an inhaler, I'll see you in 6 months, or we'll start measuring you for an oxygen hose and all that kind of stuff. And I think that really percolated down into their patient groups. When somebody tells you there's nothing we can do, you can kind of give up hope very easily for that. Fortunately, over the ensuing, I think it was 7 years, I believe they looked up until 2014, we've made huge strides in reducing that kind of nihilism and that belief that there's nothing we can do, and that has, I believe, again percolated down into people for the most part. However, there is still a large sense that this is a debilitating disease, and this is going to limit you. And anytime you get hit with when you're told that this is a chronic disease and you're going to be dealing with this for the rest of your life, that's a hit to the psyche. There's no doubt about that, and we need to be there to support people as they're moving through this process, and and that's a huge part of the awareness opportunities that we want to do as part of COPD Awareness Month and all those sort of things. We want to make sure that people realize that they aren't alone. People live with COPD for a very long time. We've got people who, like Russell Winwood, I mentioned earlier, from Australia. After his stage 4 end stage diagnosis of COPD, this man has run a couple of marathons, and he's done Ironman triathlons, and he's done all that sort of thing like that. Now, I'm not going to tell you that everybody can be Russell, but it is entirely possible to go ziplining in Belize, or to do a lot of to attend a child or grandchild's wedding. It is entirely possible to do the things that you want to do in large part with appropriate management. And so we need to do a much better job of screening for depression, helping manage depression, and helping manage feelings of loneliness and feelings isolated, social isolation, all that stuff, in order to improve everybody's quality of life. So I hope that didn't sound too soapboxy, but it's something I'm very passionate about, is trying to make sure that people don't feel alone, don't feel guilty, and don't feel lesser just because they have a particular chronic disease. So we've got one last question we're going to hit from Karen here, and then we're going to wrap things up. Changing meds to nebulizers from inhalers does seem to shorten exacerbations too. Why don't more people have that option at home? The nebs seem to be more cost effective. Well, that's what we in the medical field, because we like our big fancy worlds, like to call a multifactorial problem. And what I mean by that is there's a lot of issues at play there. For many people, we can definitely say that nebulizers can be a little bit more effective than inhalers. But that is not necessarily because the device is inherently better. It's because, if you'll pardon my French, we as clinicians do a crap job at teaching people how to use their inhalers. Part of my spiel here in the office is we as a medical system are really good at telling people to take drugs. We're not always so good at telling people how to take drugs. And so we have a lot of confusion about when to take medications, which ones are controllers, which ones are rescues, how do I breathe in, is it different between a powder and a regular traditional inhaler. Whenever we look at a scientific study, we can see that with proper use and proper technique and proper administration and a good understanding of when to take your medications, inhalers can be as effective as nebulizers. But again, we have a lot of that breakdown, and there's a lot of reason for that too, and I don't want to belabor that point too much. But the thing with nebulizers is they are far less sensitive to technique because they're blowing out all the time. You can breathe at your own rate, and they're far less sensitive to that. And so a lot of people do, from a practical standpoint, get more medication from a nebulizer. Unfortunately, we do see that we have fewer options. We got a couple of downsides to using the nebulizer. First of all, portable nebulizers tend to be a lot more expensive and out of the reach of a lot of people. And secondly, we have fewer options. For example, a medication like Spiriva or Tudorza or Incruz, a long-acting muscarinic antagonist or a LAMA type of drug, which is one of our mainstays of care in COPD, is not available in a nebulizer. So if we put people on strictly nebulizer medications, we're already slamming the door on a very valuable therapeutic method. And so there's a lot of trade-offs. They can be more cost-effective because of a quirk in Medicare. They tend to be covered under the Part B, which is the equipment phase of Medicare. And so they do tend to get reimbursed a little bit better than those drugs that are given through Medicare Part D. But again, there's a lot of trade-offs. And I did tell a little bit of I don't want to call it falsehood, but I do want to jump back real quick. I got one more area that I was looking for comments, and these are from some of my respiratory care colleagues. I don't want to leave them in the lurch on Respiratory Care Week, certainly. Michelle also points out that inpatient respiratory therapists get very little training on these new inhalers, and that's very true. A lot of hospital systems are not always willing or able to stay up on some of the latest therapies out there. And so when a person comes in with a particular inhaler that might not be on the hospital's formulary, and so the therapist might not be familiar with them, might not be able to answer any questions. So we're still looking at a lot of barriers to breaking down best practices with medications and trying to ease the continuum of care, to smooth the continuum of care for everybody out there. So what do we do for people going through DTs who need such medication they need mechanical ventilation? So you actually like to do a wean trial. It's not respiratory failure. That is something I'll actually cover in the comments. That's not strictly, most smokers die with a cardiac prior to a COPD diagnosis. That part is often very true. A lot of times the lungs or the heart will give out before the lungs, and again, we do a fairly poor job of screening and a lot of that stuff. So a lot of times people get hit with the heart issues before the COPD stuff, and that is an unfortunate reality, but a reality nonetheless. So. But I think we're going to go ahead and wrap things up here. We do need to talk. We do these talks for about an hour every time. Sandy, I will come back to that we'll try to get to that next week. We will definitely talk about some nutrition stuff as part of COPD, effective COPD management. So hopefully you'll be able to join us again next week, 1 o'clock Eastern Time. Again, through the cooperation of the COPD Foundation, you'll be able to go to their Facebook page, or you can join us at facebook.com/group/COPD Navigator. Or find us on YouTube. Find the archived copies of these videos on YouTube by searching for COPD Navigator. And if you do have any questions for next time, please feel free to leave them in the comment section below, and we'll try to get them addressed as much as possible. So until then, I hope everybody, all of my RT professionals, have a happy and safe respiratory care week. I hope everybody has a happy and safe Halloween coming up. I understand it's going to be cold in a good chunk of the country. We're talking about a little bit of snow here in Michigan, so make sure you're taking proper precautions if you're going out there in the cold. And take care of yourself, take care of each other, and have a breathe easy week. We'll see you next time.